Hello, I'm Dr. Kim Kyung-won. It's a pleasure to meet you in this online surgery session. Today, we will review a case of socket preservation performed using LCR, a newly developed material by Osstem. The patient is a 31-year-old female. The patient presented with an extraction site at tooth number 36. According to the patient, the tooth was extracted at a private clinic about 3 weeks earlier. She also reported that thorough curettage was not performed at extraction. As you can see from the intraoral findings, about 3 weeks after extraction, the socket appears collapsed and granulation tissue has not adequately filled the site. If left untreated, this area could remain as a bone defect, so I decided to perform socket preservation. On the CT scan, the tooth appears to have been left untreated for a long time before extraction. As you can see here, there is dense bone formation around the extraction socket, along with bone resorption on the buccal side. So the treatment plan was implant placement at the extraction site of number 36. The patient had also been advised previously to extract number 38, but the procedure had not been performed due to concerns about possible nerve injury. She visited our clinic hoping to have number 38 extracted as well. So, for the number 36 site, I plan to perform curettage again and proceed with proper socket preservation, as this would be advantageous for future implant placement. Previously, we used an allograft material, but today I will show you a case of socket preservation using LCR. After that, implant placement at number 36 was planned with OneGuide. What you see here are the findings during re-curettage. In the first image, the extraction socket appears collapsed, with incomplete healing. After thorough curettage, it was confirmed that the buccal wall was missing. So I performed grafting using LCR, placing a relatively large amount of graft material. The site was then covered with Osstem Soft, completing socket preservation. As you can see, a panoramic radiograph was taken about 10 days after surgery. This is the site where socket preservation was performed. On the CT scan, there was a buccal defect, so we grafted a relatively large amount of LCR, slightly over-contouring the area. This is the appearance about a month and a half after surgery. The next image is a panoramic radiograph taken about 3 months later. On the panoramic view, healing is progressing well, and the extraction site appears much improved compared with the earlier findings. On the follow-up CT scan, you can see that some graft material placed with LCR remains in the upper buccal wall. To compare it with the previous case using an allograft, I prepared these CT images. The case shown on the left is the allograft case presented previously, where the inferior alveolar canal was exposed. The case on the right is the current case. On the CT scan at 3 months, the allograft case showed limited augmentation, as the graft was not well compacted and was not extended much superiorly. In contrast, in the LCR case, cortical bone remained on the lingual side. A larger amount of LCR was grafted to augment the buccal defect area. Based on the surgical report, surgery was planned for the number 36 site using a 5.0 by 11.5 mm KS3BA implant. Socket preservation had been performed with LCR, and a slightly longer implant was selected to obtain initial stability from the host bone, as there was sufficient distance from the inferior alveolar canal. Now, let's take a look at the surgical video. First, the OneGuide template is placed in the patient's mouth to check the fit and proper adaptation. Then, the overlying mucosa is removed using a wide-type tissue punch. The template is then removed. After confirming that the overlying mucosa has been removed with the tissue punch, the template is placed again. Next, a flattening drill is used to flatten the upper area. Since the LCR had been slightly over-contoured, a flattening drill was used. Next, we performed a biopsy using a trephine drill to evaluate the results of the LCR graft. A biopsy specimen was obtained from the central area where the implant would be placed. This was done about 4 months after socket preservation for histologic evaluation. After that, the initial drilling was performed. Next, the f3.5 by 11.5 mm drill was used. Since the upper area had been grafted with LCR, I additionally used an f4.5 mm drill. Since the upper area is the socket preservation site, the bone may still be relatively soft. So, to achieve sufficient engagement with the host bone, the f5.0 by 11.5 mm drill was used. As you can see, a considerable amount of bone chips adhered to the f5.0 drill. Next, after fully hydrating the 5.0 by 11.5 mm KS3 implant, the implant was placed using an implant driver attached to a torque wrench. The initial stability does not appear to be very high. The torque appears to be slightly below 20 to 30 Newton centimeters. Let's measure the ISQ value using the smart peg. As you can see, the ISQ values are 65 and 64. Since the upper area had undergone socket preservation with LCR grafting, the ISQ values are not as high as expected. Since this was a socket preservation case using LCR, I intentionally made a small incision to check the tactile sensation of the bone. I considered additional bone grafting if necessary, but it did not seem required. The area grafted with LCR does not appear to be fully consolidated yet. So I made a small incision just to check and then sutured the site. This is the immediate postoperative X-ray. The implant was placed about 4 months after socket preservation using LCR. On the panoramic view, the grafted area is hardly distinguishable, showing that healing has progressed quite well. On the CT scan, you can see that the buccal defect area where socket preservation was performed with LCR shows good healing, appearing quite similar to the surrounding bone. As shown earlier, we performed a biopsy of the LCR grafted area. Since the biopsy was taken from the central part where the LCR graft was placed, histologic staining clearly shows good bone formation. New bone can be seen forming well between the LCR particles as the material gradually resorbs. In my opinion, although LCR resorbs slightly more slowly than allograft, it is gradually replaced by newly formed bone. As a result, it seems to maintain space better than when allograft alone is used. Even though it is a synthetic graft material, a considerable amount of new bone replacement can be observed after about 4 months. This is the panoramic X-ray taken 1 month after surgery, and 2 months later. We also took a CT at 2 months. At that time, the ISQ value had increased to about 80. Since the immediate postoperative ISQ was around 65, reaching 80 after 2 months is quite a good result. At the 2-month follow-up, the buccal defect area appears to have healed well and is quite similar to the surrounding bone on the CT scan. An ER-type prosthesis was delivered about 3 months after implant placement. This image shows the condition about 7 months after socket preservation. The CT scan taken 7 months after surgery shows good healing. And this is the panoramic X-ray taken 7 months after surgery, which corresponds to 11 months after socket preservation. On the CT scan, you can see that the buccal defect area has healed and appears to be replaced by new bone. I arranged the CT images in sequence. Compared with the findings at the time of socket preservation, the CT scan taken about 3 months later shows a slight boundary between the LCR grafted area and the buccal host bone. However, even at 3 months, considerable healing can already be observed. When the implant was placed at 4 months, although a slight boundary could still be seen, the area had healed to a level quite similar to the host bone. By 7 months and 1 year, the boundary between the LCR grafted area and the host bone became difficult to distinguish, showing good bone formation. In this lecture, I presented 2 cases. Previously, I showed a socket preservation case using allograft, and this time I showed a case using LCR. Recently, there has been increasing interest in socket preservation, and as you have just seen, LCR also demonstrates good bone formation comparable to allograft. Further follow-up will be needed, but in the case of LCR, resorption seems to occur slightly more slowly than with allograft, which may help maintain space. Therefore, LCR may serve as a useful synthetic bone substitute for allograft. Moving forward, we will review more cases and discuss them together. Thank you for watching.